I'm Dr. David Goldberg. We are here at Sanctuary Medical Center, and we're going to approach the treatment of acne with a really revolutionary method, and that's photodynamic therapy, or PDT, for acne. All right, so we're going to talk about PDT for acne, or photodynamic therapy for acne. This actually is part of a much larger talk that I have given before on PDT for lots of different things. And obviously, photodynamic therapy in a dermatology office is most commonly used to treat precancerous changes of the skin. So, some of the stuff that's obvious. There are a lot of different therapies for acne, and a lot of patients, we derms know this, a lot of patients benefit from traditional treatments, but there are enough patients, and they seem to be increasing, and their docs, who are dissatisfied with the standard approaches to treating acne, which is topicals and oral agents, whether antibiotics or Accutane. So, we're going to try to think about matching therapy to patient needs and disease characteristics, which means a 14-year-old that's got a few blackheads and whiteheads does not need PDT. Go through what we use as our treatment protocol north, and I think it's very applicable here, and try to get better clinical outcomes and patient satisfaction by focusing on some of the nuances. And it all gets back to this concept of selective photothermal lysis, and the word kind of says it all. Photo is light, thermal is heat, and lysis, we're destroying something we don't want. And in this case, by and large, what we're trying to do is decrease the count of the bacteria associated with acne, Propionibacterium acne, or P. acne. And we've got the selective tissue damage that's going to occur, by and large, in the sebaceous gland hair follicle region. And so the way we do it is, when we use photodynamic therapy for acne, we administer a photosensitizing agent. We allow it to accumulate in the target cells, which again is the hair follicle, the sebaceous glands. There's been some controversy as to how long that should be. By and large, most of us now do it for an hour. We activate it by radiation of visible light. In our offices, we tend to use, for the most part, red LED, but blue LED can be used, lasers can be used, broad-based light sources can be used, and then we're destroying the target cell because we're activating this photosensitizer. And so this is sort of the mode of action. You've got this ALA, this agent, that localizes in fast-growing tissue, and historically that was actinic keratoses that are turning over very quickly. Clearly it can be in the sebaceous glands, what we're targeting with acne, sun damage, and we're converting, in this case, this fast-growing tissue, we're converting into that area what's called protoporphyrin IX. Like I said, you can kind of pick your machine, so it's why more people don't do PDT boggles my mind, because here you're on a mecca where we have a lot of technology, but frankly most offices have something, and it's activated by almost every light source. And so there is some data already just comparing, without the ALA, without the PDT, just the light, comparing light source treatment to some of the standard treatments. And a lot of this doesn't get enough credence, because if you look, if you use blue light, again, red light is essentially the same as blue, but it goes a little bit deeper. If you look at what happens to inflammatory lesions, this is a multi-center trial, you actually see a quicker response to blue light than you do to oral antibiotics or topical therapy. And you would expect oral antibiotics to work better than topicals, that's just a given. But blue light really, and red light kill P. acne. And so there's a lot of stuff out there. This one study that looked at blue activated by ultraviolet, which we're not going to do at all. One looked at blue light treatment alone, and then a study looked at blue and red, which we've done some work in that area. And they all clearly decrease acne, and they decrease acne because they kill the bacteria without taking pills. All right, so now what happens when we add the ALA to it? So I would argue that if we're going to get some young teenagers in the office whose parents don't want them to use antibiotics, which if you don't bring it up and just give them a prescription, we do this all the time, then it's no issue. But if you start saying to the parents, well, we have an option that costs a little bit of money, it's not that expensive, but your child doesn't have to take antibiotics, a lot of them are going to think about doing that. And I would almost contend that the kids who aren't that bad can just get the light without the PDT, period. Because it's pretty easy. They just sit in front of this thing, it's painless, they love it, unheard of all, okay, and it works. When you start getting more severe acne, and it's hard to define that, but I define that as generally either teenagers or adults who have more than 10 pustules or cysts or something like that. Then we start going toward the PDT process. This is a study done on IPL, and again, I don't think it matters if it's BBL, IPL, or any of the LEDs, looking at moderate to severe acne, and now we're adding the ALA, the Kerostin, the DUSA product. And he did one treatment a week. In real life, that's not what we do. It's not real practical. And it's not real practical because when you start putting on the ALA, remember, they become photosensitive for a little while afterwards. And I'll sort of tell you about a kid that I treated a couple of years ago in a couple of minutes, and you'll see what that means. So although the study was done one treatment a week, in real life we treated once a month. 4 weeks they did, and they did a 1 3-month follow-up, and they saw a greater than 7% improvement. And I think that's pretty typical. Now, that does not mean for a minute that this is curing their acne. But it's working as well as pretty much anything else, and they're not taking the pills. And so this is Michael Gould. Now this is PDT. Now you could argue that the same result might have occurred if they just used light alone, but she's got a lot of inflammation. And so that's when I start thinking about PDT. It's not just they have pimples. And so the issue with photosensitization, which is an issue when you start throwing in the ALA, and clearly the issue down here, they really, just like any other PDT patient, they have to wear sunscreens for 48 hours afterwards, not do that well. Here's another one. It's a great example. And so another study done, Amy Taub's dermatologist in Chicago, again, moderate to severe acne. This is her regimen, so she's an acetone scrub. Yeah, you kind of want to get all the oil off the skin before you put the ALA on. That applies no matter who you put it on. We don't use acetone, we tend to use alcohol, but you can use either one. And so here, she's really cheating, because she's putting the ALA on 15 minutes, 30 minutes, not an hour. And that's part of what the acetone allows you to do, is you're really ripping off some of that outer layer. You know, we tend to put it on for an hour. And so who do we choose for this when we use PDT? Generally mild, moderate, or severe acne, and that patient who either personally or family doesn't want using antibiotics or Accutane, and or previous treatment failures, intolerance to antibiotics, you know, either stomach problems from the antibiotics, which happen all the time, women with their yeast infections, you know, so these are all the people who tend to want this. And you know, people are humans, and humans are notoriously non-compliant. And this is an easy thing to be compliant with. You just show up once a month, and that's really what it is. And so how we do it is, we typically do a little microdermabrasion at a time. So that gets the estheticians involved, frankly. Doesn't take very long, feels good, and kind of does what the acetone does without some of that irritation. And then we use an hour. That's what we do, an hour incubation period.
And excuse me, how many minutes do you do?
I do 20 minutes.
Okay, thank you.
And then our modification is solely dependent on what their response is and what the reaction is to sun. So if they look like they're not doing as well as we want, then we may leave the ALA on a little bit longer. If they get the barbecue look, then we might leave the ALA on a little bit shorter or cut back a little bit on the light. So that's something that's a judgment call. But you know, standard treatment is an hour of ALA and 20 minutes of red light.
Dr. Goldberg, do you wash them off before you put them under the lights or after?
So no, we don't wash them off before. You don't wash them off at all before you get put under the light. So you do something beforehand, whether it's acetone, microdermabrasion, something. You put the ALA on, leave it on for an hour. You immediately activate it with something, and then you wash it off. And so I'm showing this because this is a woman that we treated, and it points out what PDT can do that light treatment alone will not do. So this is someone that we treated, I believe, 4 times. Okay, so 4 months in a row, and the right side is roughly 6 months later. So not only is her acne better, but what else is better?
Sun damage is better.
Well, her sun damage is better.
Scarring, yeah.
So PDT actually creates new collagen formation, and I think of PDT as actually sort of an alternative to Sculptra, because it does the same thing. Okay, and so this is an ideal person for PDT. Because she's got acne, she's got some scarring, and both of them are going to be improved. And to me, this is the winner of PDT. And so as I said, you know, we tend to use it because people increasingly don't want antibiotics, don't want Accutane. How long we incubate the ALA is going to be all the things we talked about. You know, and like I said, I mean, BBL is fine, red LED is fine. That's it.
Cool.
Thank you.